Hi everybody, good morning. And we talked about in the previous session about just a glomerular apparatus and renin, angiotensin, aldosterone mechanism, and how it regulated the extracellular blood volume and blood pressure. So today in this video we are not just going to go in detail about the RAS system, but we will underline the RAS system, and we add a note briefly on angiotensin converting enzyme inhibitors and ARBs, angiotensin receptor blockers. Also, we'll just look into what is the controversies now existing because of the COVID-19 and what could it be beneficial or disadvantageous to use AECIs or ARBs in hypertensives. So hypertension and RAS, the renin-angiotensin-aldosterone system, regulates body's hemodynamic equilibrium, circulating blood volume, electrolyte balance, and is a key therapeutic target in hypertension, the world's leading cause of premature mortality. So we know that RAS is very, very important, and we just now briefly look into RAS too. So here we have this renin-angiotensin-aldosterone system, angiotensinogen, which is alpha-globulin from the liver is converted into angiotensin-1 by the enzyme renin secreted from the Juxta glomerular cells when there is a hypotension in response to hypertension or sympathetic activity. So now this angiotensin-1 is converted to angiotensin-2 because of angiotensin converting enzyme in the lungs, and angiotensin-2 causes production and secretion of aldosterone, and these have vasoconstriction function as well as and increases the BP as well as cardiac remodeling and stroke. So what causes this hypertensive disorders? Maybe it could be the overactive RAS, which is a main pathology behind hypertensive disorders. So use of RAS inhibitors is a very famous and prevalent medications. So how this RAS occurs? A brief idea about this we will look into now. So Juxta glomerular apparatus, as the name indicates, Juxta means near, refers to a collection of cells present near the glomerulus. This includes the afferent arteriolar specialized cells, which are in touch with the macula densa of the thick limb of ascending limb of loop of Henle, as well as the interstitial cells of Lasix or extraglomerular mesangial cells. So the afferent arteriole is the one which senses which releases renin when there is some hypertension. So this hypertension or decrease in sodium chloride concentration in the filtrate is sensed by the macula densa cells, which is specialized cells in the thick ascending limb of loop of Henle, and gives information to the juxtaglomerular cells to secrete renin, and maybe the mesangial cells they interact between the macula densa and the juxtaglomerular cells. So now renin is secreted in response to the hypertension or decrease in the blood pressure as a physiological mechanism to bring back the bring back BP back to normal. So again you can see the juxtaglomerular apparatus, afferent arteriole, efferent arteriole, and the renin and the macula densa. Okay, renin and the juxtaglomerular cells of the afferent arteriole as well as macula densa. Don't forget this. So now we know where renin comes from, and this comes from the from the cells of the juxtaglomerular apparatus, which is the juxtaglomerular cells, which are modified muscle cells of the afferent arteriole, and macula densa or the thick limb of loop of Henle senses it acts as a chemoreceptor and senses pressure changes or the electrolyte changes, and mesangial cells releases information to the juxtaglomerular cells to modify the function of the afferent arteriole or efferent arteriole, so that the BP comes back to normal at the kidney level as well as at the systemic level. So the function of the juxtaglomerular apparatus is a tubular glomerular feedback mechanism which controls the tubular function, renin-angiotensin system, which regulates the blood volume and pressure and erythropoiesis. So here we just want to concentrate on this renin-angiotensin system, which regulates the blood volume and pressure. So renin-angiotensin-aldosterone system, which already we knew, consists of the renin, the angiotensin, and the aldosterone. So whenever there is a decrease in the perfusion pressure, juxtaglomerular cell secretes renin, angiotensin 2 is formed, which causes constriction of the arterioles in the kidney, and it causes increase in secretion of aldosterone, an antidiuretic hormone, as well as increases thirst mechanism. Renal failure sometimes develops in patients with poor renal perfusion who are treated with angiotensin converting enzyme inhibitors, because angiotensin 2 is not formed, and it can develop less perfusion of your kidneys, and they can go in for renal failure. So angiotensin 2, how it acts is, it is a very potent vasoconstrictor. It stimulates the systemic BP by acting on the heart and all the blood vessels and returning the BP back to normal. As well as it causes more of aldosterone secretion and ADH secretion, so that water reabsorption occurs and sodium reabsorption occurs, as well as there is excretion of potassium as well as hydrogen ions. So the enzyme which is responsible for the conversion of angiotensin 1 to angiotensin 2 is angiotensin converting enzyme in the lungs. So here I want to stress you on ACE2, where the angiotensin 2 is converted into angiotensin 1,7 by the ACE2, and this is equally prevalent at low doses. Angiotensin 2 is converted into angiotensin 1,7, which has a vasodilatory metabolite. Angiotensin 2, as we look into under physiological conditions, it causes brings back BP back to normal and increases the systemic volume as well as blood volume. But under pathophysiological conditions, when there is increase in the angiotensin 2, and it causes increased hypertension and increased volume overload in the extracellular compartment, and causes deleterious effects. So here you can see this angiotensin 2 under pathological conditions can cause a deleterious effect, and we have an angiotensin 1,7 which is a vasodilatory metabolite, and it is good, and it is a normal healthy individual has good amount of angiotensin 1,7. Another function of ACE is to inactivate bradykinin, so that the bradykinin effects are reduced. Bradykinin is a vasodilator or inflammatory substance, and its activity is reduced. So there is no vasodilatation and the BP goes back normal. So that is another function of ACE inhibitors that you got to remember, because when we talk about ACE inhibitors or ARBs, we got to remember the most important side effect is angioedema, and it is because of the bradykinin. When ACE is blocked and you do not have bradykinin getting inactivated. So now here ACE2 also we got to see, which is an enzyme which converts angiotensin 2 to angiotensin 1,7, which causes vasodilation and acts opposite of RAS. So the function of angiotensin converting enzyme 2 is it decreases BP, it is anti-inflammatory, antioxidant, and it is a dominant one which is present in the healthy individuals. So this you got to remember, because under this recent infections and scenarios where the COVID is making huge mortalities around the globe, we got to remember this ACE2 and its pathology and its significant role in whether it is increasing the COVID-19 or it has a role in bringing less mortality among these patients who are taking antihypertensives. So here you can see angiotensin 2 is converted to angiotensin 3 and angiotensin 1,7, which is very important in healthy individuals. So how does angiotensin 2 acts? It acts on the two receptors, angiotensin 1 and angiotensin 2. Angiotensin 1 and angiotensin 2 actions balance each other to produce certain physiological mechanisms. Most of the mechanisms are produced due to angiotensin 1, AT1 receptors. That is the predominant one, and this causes vasoconstriction, cell growth in the heart and the arteries, and secretion of aldosterone and peripheral sympathetic activity. Angiotensin 2 has an opposite effect, causing vasodilatation and antiproliferative and apoptosis action. So angiotensin 1 is the most important receptor through which angiotensin 2 acts. Okay, so you got to remember angiotensin 1 means it is the receptor 1 type of angiotensin 2. Okay, angiotensin 2 means it is the second type of receptor of angiotensin 2. So angiotensin 2 is the most important potent vasoconstrictor. It helps to re-establish fluid balance and normal BP by blood vessel constriction. It increases renal and gastrointestinal salt and water reabsorption. Through aldosterone production and ADH production, it also increases sodium reabsorption. So one of the most potent vasoconstrictor, it helps to re-establish fluid balance and normal BP by blood vessel constriction. Increases renal and gastrointestinal salt and water reabsorption, aldosterone production and ADH production. So aldosterone increases sodium and water, sodium reabsorption, potassium secretion and hydrogen secretion, as well as ADH production causes increase in the reabsorption of water through the formation of aquaporins. These are the functions of angiotensin II, which re-establishes water, extracellular fluid volume and BP. The actions on the cardiovascular system includes ionotrophy, chronotrophy, and positive ionotrophy, chronotrophy, and catecholamine release. Catecholamine sensitivity is increased, and cardiac remodeling and vasoconstriction occurs through 81 receptors on peripheral vessels. Through 82 receptors, it impairs cardiac remodeling. So here you can see the functions of angiotensin II. One, increases sympathetic activity, increases renal tubular reabsorption of sodium chloride and excretion of potassium and hydrogen, and water retention occurs. Acts on the adrenal gland, causes secretion of aldosterone, and it causes increase in this tubular reabsorption. It acts in the vessels, causing arterial vasoconstriction and increase in the blood pressure. Acts on the pituitary gland to secrete the ADH, which causes water reabsorption through the formation of aquaporins, and these ones act due to the release of renin from the Juxta glomerular apparatus whenever there is a systemic hypotension or renal perfusion is decreased. So we got to look into this receptors of angiotensin II, which is angiotensin 1 and 2, which we already talked about. What is the predominant role is, and it's the role of the angiotensin 1 receptors, where the systemic vasoconstriction and antidiuresis effect occurs, and it causes increase in the BP. 82 causes a decrease in the BP and vasodilation antiuresis, but 81 is the predominant function of angiotensin II, that is the most prevalent one in system. So now we know angiotensin II causes increase in the vasoconstriction of the blood vessels. So you have, if it is more action of angiotensin II is there, which can cause macrophage infiltration, which can increase the TGF beta levels and the extracellular matrix, and it can cause glomerular sclerosis and tubular interstitial fibrosis in the kidney. It can increase the glomerular permeability too, and it can increase the extraglomerular pressure too, so it can cause the proteinuria as well as renal failure. So this is very important deleterious effect of angiotensin II. So we know the aldosterone comes from the adrenal gland, and the angiotensin II is the one which causes secretion and production of the aldosterone, which causes sodium reabsorption, potassium secretion and hydrogen secretion, and this causes decrease in the BP. This is the physiology behind aldosterone. So what happens, what is the deleterious effect of aldosterone? It can affect the autonomic nervous system, causing a reduction in the RR variability, the heart rate variability increases. It can prolong the QT interval, and it can cause sudden cardiac death. On the heart, it can cause cardiac fibrosis, myocardial hypertrophy, and impaired systolic and diastolic function, and it can lead to heart failure. In the kidneys, glomerular extracellular matrix deposition can occur, and it can cause potassium depletion. So when the aldosterone is stored, it can cause an hypokalemia. On the brain and baroreceptors, it can increase the sympathetic activity and the parasympathetic inhibition. Vascular smooth muscles, it can cause vascular growth, remodeling, reduced vasorelaxation, and pro-inflammatory. On the endothelial level, it can cause decrease in the sodium nitrous oxide, reducing the vasorelaxation, and increased reduction of leukocytes and platelets. It can be atherogenic. So these are the deleterious effects of aldosterone. So what is this relationship between this aldosterone and hypertension is? In the brain, there is increased sympathetic activity and parasympathetic inhibition. On the kidneys, there is increased renin activity, causing salt and water retention, and glomerular extracellular matrix deposition and potassium depletion. As a beta receptors, it causes a reduce in the beta receptor function, and the blood vessels reduced nitrous oxide causes increased peripheral vascular resistance and decreased vascular compliance. All these can lead on to your hypertension. So, what are the drugs and the system of drugs which acts or interacts with the RAS system? So, you can have three groups of drugs here, four groups of drugs as such. We can name it like DRI, which is a direct renin inhibitors, which can inhibit the conversion of angiotensin 1 to angiotensin 2, which is ACE inhibitors, which we can inhibit the ACE enzymes. Next group of drug is the ARBs, which are angiotensin receptor blockers, which can block the receptor 81 so that angiotensin 2 does not act. Or it can cause the inhibition of aldosterone so that the deleterious effects of aldosterone is not there. By doing all these things, we can bring back BP to normal. These are the famous drugs, antihypertensive drugs, which are used today. So briefly, we look into these drugs. So here we can name them. You can see the renin is inhibited by the renin inhibitor, aliskirenin, maybe you can remember this. Angiotensin converting enzyme inhibitors ends with pills, okay, captopril, enalapril, and so on. The list is very long. When you look into angiotensin 2 receptor blockers or ARBs, it ends with the sartans, okay, losartan, telmisartan, and so on. Also, what we have is the aldosterone antagonists like spironolactone and eplerenone. So these are the ones which can decrease your BP and are very useful antihypertensive drugs. So here, renin inhibitor reduces renin, which is a rate limiting step in the formation of renin-angiotensin system. You can use ACE inhibitors, which can reduce the formation of angiotensin 2, and it will cause increase in the bradykinin because bradykinin is not cleaved by the ACE, and you can have angiotensin 2 receptor blockers. So that it affects the renal actions, aldosterone secretion, antidiuretic hormone secretion, cellular growth, vasoconstriction, sympathetic stimulation, pressure effect, and thirst. So when all these actions are stopped, so it has an impact on the kidney functions, sodium reabsorption, potassium secretion, and water reabsorption, cellular growth, vasodilatation, sympathetic stimulation is decreased, pressure effect is reduced, and thirst is decreased. So what are ACE inhibitors? An angiotensin converting enzyme inhibitor is a pharmaceutical drug that used primarily for the treatment of hypertension and congestive heart failure. They are medications that slow or inhibit the activity of enzyme ACE, which decreases the production of angiotensin 2. They inhibit angiotensin converting enzyme, an important component of renin-angiotensin system. So what happens when you use ACE inhibitors? They reduce the levels of pro-inflammatory markers and prevent atherogenesis. They inhibit fibrosis and reduces endothelial dysfunction. They decreases the concentration of plasminogen activator 1 and the tissue factor inhibitor it is, so that the atherogenetic potential is brought down because of use of ACE inhibitors. So what are the inhibitors? ACE inhibitors, I told you it ends with the pill, captopril, ramipril, enalapril, and so on. The usage, as we talked, it is very important drug for the hypertension. It can be used in congestive heart failure, myocardial infarction. It can be used as a prophylaxis of cardiovascular risk, increased risk in subjects with cardiovascular problem. It can be used in diabetic nephropathy. This is very useful drug in diabetic nephropathy, and it can be used in scleroderma crisis. So it is a miraculous drug there. Side effects of these includes, one is the persistent dry cough and the allergic reaction or the angioedema. The proteinuria can be there and potassium levels can be elevated, hyperkalemia can be there, taste sensation is altered, metallic taste sensation can be there, it can cause angioedema, photosensitivity can occur, and renal failure, indigestion or GIT symptoms are altered, GIT symptoms are there, and it can cause hypotension. So orthostatic hypertension or the blood pressure monitoring is very important when you use ACE inhibitors. So what is the use? Again, we refresh. It is used in hypertension, congestive heart failure, myocardial infarction, diabetic nephropathy, psychogenic polydipsia because it reduces the thirst, nephrosis in systemic sclerosis and other vascular diseases. In diabetes patients, this is very important drug, and it can slow down the progression of diabetic nephropathy because this drug decreases the proteinuria. When the diabetic nephropathy is there, the proteins are not reabsorbed, and there is. So what is the use of this drug? So as we already talked, it is very useful in hypertensive patients, congestive heart failure, myocardial infarction, diabetic nephropathy, psychogenic polydipsia, nephrosis in systemic sclerosis, and vascular diseases. So in what way it is very useful in diabetic nephropathy? In diabetic nephropathy patients, there is no reabsorption and the proteinuria is there. There is loss of proteins in the urine. So when we use this ACE inhibitors, the proteinuria is decreased and it can slow down the progression of the disease in the diabetic nephropathy. We know that it causes a thirst sensation to go off, so it can be used in the psychogenic polydipsia. So in other diseases also it is very useful. How it is useful in congestive heart failure? So when the heart is failing, what happens is when you use ACE inhibitors, this decreases the preload as well as the afterload because it causes a vasodilatation and it decreases the afterload. It causes decrease in the reabsorption of sodium as well as water, and there is a decrease in the blood volume, and this can cause a decrease in the preload too. So this can help the patients with the congestive heart failure. So beneficial effects of angiotensin receptor blockers when we go into ARBs, receptor blockers. So we'll come back this after we'll look into the ARBs. Okay. So the side effects of the ARBs includes the dry cough, increased dry cough. This is because of increased contraction of non-vascular smooth muscles, causing bronchoconstriction because bradykinin is there. Because bradykinin is not taken off. Angionephrotic edema, increased pain and vasodilatation, and this is because of bradykinin, because it is not clean, because ACE enzyme is not there. It causes increased natriuresis, hyperkalemia, acidosis occurs, hypertension occurs, kidney problems can occur because it can decrease GFR, it is teratogenic and it can cause GI symptoms. So the contraindications to use ACE inhibitors is, we can remember the mnemonics P is for pregnancy, A for allergy or angioedema, R is for the bilateral renal artery stenosis, and K is for hyperkalemia. We should be very careful with the hereditary angioedema patients too. These are the contraindications. You can see the angioedema here developed because of the use of ACE inhibitors. This is because of the active bradykinin. So when you use long-term treatment with ACE inhibitors, there is say that the angiotensin levels increases slowly, and there is an escape of this angiotensin 2 levels to the pre-treatment level, so that the hypertension is not coming under the control. This escape effect is related to the angiotensin 2 and aldosterone, and this could be because the kinase, which is an enzyme from the heart, can cleave the angiotensin 1 to angiotensin 2, and angiotensin levels prevail again to the pre-treatment level, and this can be the cause for the BP not coming under control after a long-term treatment. So we know the ACE is a very important one, which causes the conversion of angiotensin 1 to angiotensin 2. So ACE inhibitors block this ACE. Okay, so I have here narrated the kinase here mainly responds in the heart. So when we talk about the ACE, in the situations of COVID-19, we got to remember what is its connection with the ACE inhibitors. So what is coronavirus? This is COVID-19. We already knew much in detail about these ones. It is a pandemic. It interferes with the RAS through the renin-angiotensin converting enzyme 2, and this is physiologically encounters the RAS activation, but also functions as a receptor for SARS virus. So this is very important to know how this COVID-19 and the RAS interacts. So the ACE2 is the receptor through which the virus enters. So spike protein, which is present on the SARS-CoV-2, this one, functions as a lock, like a key, and it ends into the human cells in the lungs. And this is a portal of entry. ACU2 is the portal of entry for this SARS. So when you have ACE inhibitors using this, they say that there could be an upregulation of this ACE inhibitors and it can be deteriorated. That is an hypothesis, but it is not proved like that. So what is the controversy in using ACE inhibitors in this COVID circumstances? Does ACI1 upregulate the ACE2 receptors, which can deleterious effects can occur in the patients using these hypertensions and can cause mortality? Also, there is papers coming up and there is publications occurring saying that ACE have low concentration of angiotensin 2, so that angiotensin 1,7 is formed, which is very important in causing vasodilatation, and it is an anti-inflammatory and antioxidant, so that it is very useful to the patients to come out of this infection. But AT1, which is attached to ACE2, how this occurs is AT1 receptor, which is the most important receptor for the angiotensin 2 to act, attached to the ACE2 at the low concentrations of angiotensin 2 in the plasma, so that no ACE is available for the SARS virus to act. What about ARBs? ARBs bind to the AT1 receptors. AT1 receptors to ACE2 and keeping them intact, so that there is no ACE available for the SARS to act on. So these are the hypotheses, and we got to evolve into much more details and the publications and coming up research to look into whether it is very, very beneficial or not beneficial, because stopping the antihypertensives in patients, in elderly patients, can deteriorate the conditions because they have uncontrolled hypertension and increase in the angiotensin 2 levels, which can cause a cardiac remodeling and can enhance the infections. So we got to use under scrutiny these drugs, and it's not ideal to stop the ACE inhibitors because it might have a beneficial effect in compacting hypertension and bringing the BP back to at control, so that these patients with hypertension and diabetes have decreased mortality. So here I want to talk to you about the SHADDASE2. SHADDASE2 is the one which cleaves the ACE enzyme, so that it can go and act on convert angiotensin 1 to angiotensin 2. So if you use a exogenous SHADDASE, okay, it can cleave the ACE inhibitors, and these substrates are not available for the virus to enter into the cells. So substrates are cleaved and it is not available for the viral entry. So we got to benefit the risk and the infections and use with caution in this absolute time of crisis with coronavirus. So the mode of action of ARBs also limits the deleterious effects of angiotensin 2. ARBs prevent the binding of angiotensin 2 AT1 receptors. So it causes vasoconstriction, sympathetic stimulation, oxidative stress, release of inflammatory factors, aldosterone release, or effectively reduced by the action of ARBs. So now we are talking about the ARBs, or the angiotensin receptor blockers. So it blocks the angiotensin 2 acting on its receptor angiotensin 1, and all these deleterious effects of angiotensin 2 is stopped, and you bring back BP to normal. So here it blocks at the receptor level, angiotensin receptor blocker. So what is the use? It can be used in hypertension, congestive cardiac failure, diabetic nephropathy, vascular disease, atherosclerosis, diabetic nephrosis, and Marfan syndrome. As I already talked to you, in CHF this is very, very useful because of it decreases the preload and the afterload. In diabetic nephropathy, it decreases the proteinuria, so it slows down the progression. So what are the effects? The same effects as ACE. We have the side effects of using the ARBs too, but most important one we should not have is angioedema and bradykinin, because ACE is paired and bradykinin is cleaved, and you do not have active bradykinin, so that you do not have angioedema or dry cough. But what do we have is hyperkalemia, orthostatic hypotension or dizziness can occur, weakness, syncope, headache, nausea, vomiting, GI symptoms, diarrhea, metallic taste, rash, and renal failure can occur, insomnia, and you want to look into the liver function test too. So these are the side effects of ARBs. So contraindications is you do not use in pregnancy, you do not use in patients with angioedema. So what are the things which you got to use with caution is, along with the diuretics, monitor potassium levels, look for the renal failure, you do creatinine level, urea creatinine level, you look for the liver diseases, look into the LFTs. You don't give potassium supplementation because already that is. So, what caution we should have when we use along with the diuretics? We've got to be very, very careful, because the diuretics can cause a depletion of water, and there is diuresis occurring there. So along with these ones, ACE inhibitors or the ARBs, they can cause much of the diuresis, and it can cause much more hypertension. You got to monitor the potassium levels, because the aldosterone is not working and you have no potassium excretion and hyperkalemia is there. So you got to look for the potassium levels, and that could be a renal failure, because renal failure, and also it is a risk in the severe heart failure patients, because it can decrease your GFR much more further, as well as in the severe heart failure patients, because it can further decrease your preload and afterload. Also in patients with liver diseases, you got to look for the LFTs. Even in the normal people, you got to look into the LFTs. You got to be cautious with using the potassium supplementation, because already there is hyperkalemia, and you got to use a potassium diuretics, aspirin diuretics, aspirin and lactone, because it can increase the potassium levels, and it can have a deleterious effects on the heart, causing dysarrhythmia. Also, when you stop the drug, you got to be very careful with the rebound hypertension. So these are the cautions with which we got to use the ARBs and ACE inhibitors. So here you do not use ACE inhibitors in pregnancy, history of angioedema or dry cough or allergy to ACE or ARBs, and ARBs we should not use in pregnancy and cough if you have an allergy. And you can use with caution with women who is not practicing contraception, but in bilateral renal artery stenosis you do not use ACE inhibitors, and also drugs which causing hyperkalemia, you should be using that with caution. So in ARBs also, it is a contraindication is bilateral renal artery stenosis, drugs causing hyperkalemia, and women who do not practice contraception, and angioedema due to ACE inhibitors. So these are the important contraindications. You should not use ARBs or ACE inhibitors. So thank you. So when we talked about the ACE and the ARBs today, ACE inhibitors and ARBs today, so we knew it is a very, very potential and beneficial drug in bringing down the RAS and bringing down the action of angiotensin 2 as well as your aldosterone levels, so that it compacts the hypertension and brings back your blood volume and your BP back to normal. But under these conditions of COVID-19, please do keep in mind about the COVID-19 and its substrate, that ACE2 enzyme which is present in your lungs, which can be a portal of entry to the SARS virus. So here we got to be using antihypertensives, ACE inhibitors and ARBs with caution. So thanks for the patient listening. You can comment on these videos, you can post your queries down in the columns, and you can go into the further videos in this channel, and you can enhance your knowledge. And whatever the comments, you can post it in the comment section, and please do keep in touch. Thank you.